are Dr. Margaret Tromp and Karen Brooks. Now, if you are interested in receiving a letter of completion for today's session, you must have registered for the webinar and complete the pre-learning assessment. If you haven't done that already, it will be open for the next 15 minutes through our website. Next requirement is to log in and view the full hour of the live webinar session. In order to track your participation, we will need you to have logged in using your first and last name. If you have not done that, or if you are viewing as a group, you can email me by end of day today with a list of the individual's names. And then following today's session, you must complete the evaluation and post-learning assessment that will be emailed to you tomorrow. As well, you have a copy of the slides download over here. You just have to click on the actual name of the document and then select download file at the bottom here. Our webinars are being live tweeted. Follow the CAMH Nicotine Dependent Services on Twitter at @PSQuitSmoking. To follow the live tweeting or to post your questions or comments, use the following Twitter hashtag #TeachWebinar. Okay, so now a little background on today's presenters. Dr. Margaret Tromp is a family physician in Picton, where she is a full-spectrum practice. She is a member of the Prince Edward Family Health Team and an adjunct associate professor in the Department of Family Medicine at Queen's University. Dr. Tromp spent her early career working in rural and remote areas, including Ethiopia, Labrador, Northern Ontario, and Saskatchewan. She is also the EMR lead for the Prince Edward Family Health Team and is also a member of the Board of Directors and the Quality Improvement Committee. She is committed to integrating chronic disease management and prevention into her office. Next is Karen Brooks. Karen is a caring, committed registered nurse with over 35 years of healthcare experience in both hospital, surgery, acute medicine, critical care, cardiac step-down, and as a family practice nurse, certified respiratory educator, certified tobacco educator, and chronic disease patient educator. Karen has been a guest speaker for the University of Ottawa, SELIHN, RNAO, CNRC, Better Breathing Conferences, and AFHO. She was a curriculum planner for the most recent CAMH Ontario Lung Association publication of the book Motivational Interviewing in Respiratory Care, and she is a valued and active member of the Canadian Celiac Association. Recently, Karen was presented with the Queen Elizabeth Diamond Jubilee Award for her work with the CCA, and her latest achievement has been a 6-year project of co-creating and launching the first Canadian celiac online course on celiac disease, non-celiac sensitivity, and the gluten-free diet. Karen is a true believer in lifelong learning and has a passion for education. There are disclosures. No disclosures from our presenters today. Teach curriculum and slides were developed and compiled with funding from the Government of Ontario, specifically the Ministry of Health and Long-Term Care. Content of slides are primarily based on evidence-based guidelines from the following sources. These materials, as well as a verbal presentation and any discussions, set out only general principles and approaches to assessment and treatment, and do not constitute clinical or other advice to any particular situations, and do not replace the need for individualized treatment. Okay. Now, before I hand it over to our presenters today, I'm going to ask a few polling questions. First one is, what discipline does everyone come from? Just to get a sense of our audience today. Stop the poll now. So it looks like an overwhelming percent, 24% of you are registered nurses. Thank you for your response. The next question is what type of organization you work for. Okay, here we are. Okay. And about 33% of you are from family health teams. And the last question is, what region are you from? and about 20% from the Southwest area. So thank you everyone for your participation and your responses. I am going to hand it over now to our presenters today.
Okay, hello everyone and welcome. I'm Margaret Tromp, and Karen and I are just going to switch back and forth between various relevant parts of the presentation. Okay, so the first thing is making slides move. Okay, so we just like to do a little quick poll of our own, and how many people are doing smoking cessation using the STOP program in their family practice office right now as a STOP implementer. So quite a few people are.
She has to finish the end of the poll.
Okay. Try advancing? Okay. So, sorry, with the polls, I'm not sure if people see the results or not. Are they visible to everyone? Tanya?
Yes, they are broadcasted.
Okay, okay. So we got, as you can see, it looks like a lot of people are doing some form of smoking cessation in their office. Okay, now, can you get rid of that? Oh, yes, okay.
Yeah.
Okay, so what we are doing in our office as we are implementing aspects of the Edmonton South Side primary care chronic disease model and using upstream approaches for preventing problems. And this is done with an emphasis on respiratory care and smoking cessation. So in some models of care, things like COPD, smoking, asthma, that type of thing, patients go off to clinics that are not integrated right into their family practice, and we thought it would be more effective to integrate everything. So that's what we are doing. Oh, yes, you're going to do it. Okay.
Okay. No, you
Okay. Oh, yeah, no, I mean, we're doing that. We're just organizing who pushes the buttons. Okay, so in our practice, a client or patient may be seen by the nurse educator, the family physician, or both, and spend time discussing disease management and smoking cessation. So there are a few things. Smoking cessation counseling tends to be a little bit time intense, takes a little bit of time to go through everything, and but we do have a lot of patients who are smokers who we would like to promote prevention by getting them to be non-smokers. So by having someone in the office who concentrates on the smoking cessation, that frees me up to do the other parts of family practice. And this also means that if patients have chronic diseases and they are smokers, all these different things are handled within the family practice office, and we can often multitask and deal with more than one of them at a visit. So in our practice, we have two physicians, one chronic disease management nurse, one office nurse, receptionist, that type of thing. Between the two physicians, we have about 1,500 patients because we're both part-timers who do other things. And our family health team has 23 physicians, and I also do a fair bit of counseling, prenatal care, and a lot of admin-related type things. And Karen is a CDM patient educator who's done the TEACH. She's a certified respiratory educator and a certified tobacco educator. As mentioned, she's won the Diamond Jubilee Award for her patient education work, and has done the work on the CAMH Motivational Interviewing and Respiratory Care book, and we have 3 stop implementers in the family health team, so Karen's one of those. And she also has the training for asthma, COPD, pulmonary fibrosis as well. Okay, in our area, we're in the Southeast Lynn in Prince Edward County. The county has a population of about 25,000 people. We're a medium income type area with 10.4% unemployment. There are chronic job shortages. We have a relatively aging population, having the oldest census district in Ontario. We also are a tourist area with the Sandbanks Provincial Park, and we also have a lot of wineries in our area. We're 20 miles from the Mohawk Tyendinaga First Nation Reserve, and unfortunately, because there are cheap cigarettes for sale there, this does have some effect, we believe, on our smoking rate. We have our area has one of the highest smoking rates. There are challenges with all aspects of the social determinants of health in our area. Although our average income looks not too bad, we are an area for a lot of somewhat wealthy retirees move here from Toronto, and then we also have quite a few not so well-off people. So I would say that the income disparity is higher here than a lot of other rural areas. Okay, so in our family practice, we work throughout the lifespan and see a little bit of everything. So prenatals, postpartum, well baby, sick baby, as you can see here, everything throughout the spectrum. And although we don't have a high Native population, we do have some of the Native people from the Tyendinaga area who are in our practices.
So I'm Karen Brooks, and we're just turning the screen a little bit here so that I can do the next few slides. So I'm sure all of you are somewhat familiar with the CANADAP guidelines, the clinical practice guidelines for smoking cessation. I have to say, in honesty, when I had done my teach, and we all remember those 5 days of 3-day core and electives, I know many of the teach staff spoke on CANADAP, and I have to say I really didn't totally take that all in at the time. It was so overwhelming, all the great information. And then as I studied for my CTE exam, one of the extra added things was the knowledge of CANADAP, and I really started to investigate them and thought, gee, you know what, I probably just missed the boat. Other people are on board, but I didn't realize how much CANADAP guidelines could fit into family practice. So that's basically what we wanted to show you today. So for those of you that are not aware, I did put in a little CANADAP vision, but basically it's to encourage a Canada where healthcare providers have access to tools to help deliver the best evidence based on smoking cessation interventions. It was developed in collaboration with national experts in tobacco cessation and health change behavior. And I know it looks like another document, but I encourage you just to spend more time having a look at it because it's really helped me be able to do a better job in our office for smoking cessation. Okay. So our next question is a poll for you as well. Again, do you use CANADAP guidelines in your family practice setting? So there's a yes or no aspect. So as you can see, 41.5% of you said yes, you do use them, and great job, and about 58.4% said no. So that makes me feel better because I was really hoping there'd be a lot of people that didn't feel they were using them I kind of took a shot on the dark in doing this presentation because I knew that I hadn't, so I was hoping a lot of you wouldn't too, and this would be meaningful to you. So we're just going to go through, and maybe you could pick up little tidbits of information on how you could do this as well. I have to go back to so I'm just going to advance this slide here. Okay, so there's our poll, and we've done that. So for those of you that haven't implemented them, I'm just going to do a basic review, and then you can get those documents and read them at bedtime tonight. So the Canada guidelines goes a lot in correlation with our 5As, and if any of you remember your TEACH training or your CTE exam, you always want to remember your 5As. So I'm just going to quickly review them. We ask all patients about their tobacco status, and I just want to really encourage you in this day and age with blunts and Shiska pipes and marijuana and all sorts of things to chew and snuff that we really need to ask any form. Day after day, before I implemented this aspect, people would tell me, no, they didn't smoke, but it would come out a couple of minutes later that they did blunts. And a lot of people don't consider those other areas smoking or tobacco use. So please stay in any form. It just saves a lot of time and helps to narrow that in. Number 2, advising to quit, and of course we do want to do that, but we really want to do number 3 in assessing the willingness to quit, their stage of change, and the appropriate approach. So you guys remember pre-contemplation, contemplation, and preparation, but we all know for each of those stages there's an appropriate approach. So obviously if someone is in pre-contemplation, not interested at all, we're not going to pull out the stop enrollment forms and send them out of the office with free nicotine replacement therapy. Number 4 is assisting. So we know the minimal interventions can be as short as 1 to 3 minutes, but if we have some of those, we're planting seeds. I see in pre-contemplation, there's always that minimal intervention. People are gracious enough in the office with me, they'll give me a minute to kind of plant that seed. We may feel that's useless over time, but people remember when they come back. We do know that at the proper stage of change, the appropriate approach then becomes more intensive interventions. And these people will let you know when they're ready for intensiveness. We don't want to give that to them before they're ready. Counseling by a variety of formats. Can't stress this enough. I've done this for 6 years now, and I want to encourage you. 6 years ago, I didn't know anything about smoking cessation. But what I do know from teaching individuals in the other things that I've done in life is that I've never taught people anything or counseled people about smoking or in any COPD or asthma education, in that each session is different because their learning styles are different. What they're interested in is different, so it can't become a template of tics. You really have to focus in on what these people are looking for and how they best learn. Multiple sessions, we know, prolonged abstinence, 4 or more sessions, it's been statistically proven are more effective. Combining counseling and cessation meds. I'm going to talk a little bit more about that shortly and how Margaret do that. How we do it in the office. Motivational interviewing, willingness to engage. Now, you know that I'm an avid supporter of motivational interviewing because of the work I've had the privilege of doing with the Ontario Lung Association, CAMH. But I have to tell you the biggest lesson in motivational interviewing is learning to dance with people and let them lead instead of fist fighting with them. Their willingness to engage, listening for their change talk, doing things on their terms. And we'll talk a little bit more about that later in the presentation as well, and good counseling and support. Number 5, arrange. The healthcare provider should conduct regular follow-up, support, and modify the treatment. I cannot stress enough follow-up today, and if one of the take-home messages for today, if I had a wish list, would be follow-up, follow-up, follow-up. And of course, the last is relapse. We know the first 2 weeks, these people are very vulnerable to relapse, and the first 12 months are a very vulnerable time. And again, my take-home message of follow-up, follow-up, follow-up. I just want to talk for a minute about the Canada vulnerable high-risk populations. There's 5 that are considered high-risk populations: pregnant, breastfeeding women, youth, children and adolescents, mental illness and or substance use disorder, hospital-based populations, and First Nation Inuit and Métis populations are very vulnerable. So I want to keep those in mind And now what I wanted to do, because I'm very visual myself, is I wanted to put together a chart where you could see family practice on the left. I do have a pointer here. I'm going to branch it and try and poke that without stopping the sharing and ending the presentation. So over here you can see the family practice, and these are all the things that Margaret does in the office that we've talked about. And on this side is the Canada guidelines that the vulnerable populations now. So you can see now how these correlate, the pregnant and breastfeeding with prenatal and postpartum on Margaret's side, young children and youth, vulnerable populations, the mental illnesses. I've coordinated them all, the hospitals, visits post congestive heart failure, COPD, or post-op cardiac, CABs, anything, and of course our rostered patients for the First Nations on the left. It goes with our vulnerable population. So I guess for me, when I studied Canada guidelines, I begin to realize that we have these people in the office every day that I just needed to zero in and do a better job for Dr. Beach and Dr. Tromp in the vulnerable high-risk population. So all in our day would consist of, I would see most patients first and write an initial assessment, and then I would also complete all the preventatives and lifestyle things. And of course, that's a wonderful time with lifestyles to talk about smoking, to do our minimal interventions, to plant the seeds. Of course, alcohol use goes with that exercise. And this is over and above all my respiratory education that I would do. So these are just a few examples that Margaret and I picked for things in a typical day where we kind of shoot smoking into the regular visit. So it's not unusual in our office. Sometimes people laugh at us where one may come in for a pap smear and leave enrolled in the STOP program with free nicotine replacement therapy as well. They may come in for a weight loss referral for bariatric surgery and end up, of course, having a smoking session and a quit date plan, because we know these people have to be quit 6 months prior to that procedure. They may come in for COPD or asthma education because of a recent shortness of breath sign and symptom, and they're coming back for their pulmonary function test results. So it turns into, guess what, a smoking cessation counseling. Or they may come in with a child with a viral-induced asthma and have education on second and third-hand smoke along with the asthma assessment. And of course, the mother ends up enrolled in the STOP program, leaving with free nicotine replacement therapy and a plan for smoking cessation. So we just are able to kind of scoot that in inadvertently. I'm just going to talk for a minute about the first vulnerable high-risk population. And I just wanted to also say, glad to have you write questions on the side there, and Margaret will kind of keep an eye on it. I think Tanya will too, because I know that sometimes if you wait till the end of a presentation, you forget what you want to ask. So we're more than willing to have you ask questions as you go. So the first vulnerable group is prenatal or breastfeeding and postpartum. So as we mentioned earlier, Margaret has a high number in our practice, and those that are also referred to her by other physicians in the family health team. This is just a golden opportunity to ask. Smoking related to pregnancy, we all know about those from our TEACH training, the complications, the neonatal effects. And of course, we remember the Canada guidelines. Their first line is always counseling. Second line is counseling with short-acting nicotine replacement therapy. And Dr. Selby's golden rule, I think I've done several electives, but one of the electives I did was women through the lifespans, and the importance that up to 25% of people can miscarry in the first trimester, and you sometimes want to hold back with the nicotine replacement therapy because you do not want them to feel that the nicotine replacement therapy anyway may have caused a spontaneous miscarriage. Also a great time to talk about smoke-free homes. Margaret has an ultrasound in the office, so people are always asking her to see the babe, and they'll bring in their spouses. And of course, once she lay eyes on that baby, be it a blob or little arms and legs are already showing, people will basically move heaven and earth for that baby. So it's just a great time to bring that aspect of smoke-free homes in. Because Margaret does the prenatal visits for herself and other physicians, we see these people monthly, bi-monthly, and weekly as their pregnancy progresses. It's a great time for several minimal interventions to multiple sessions. So then the person starts coming in for their prenatal visit and smoking. And everybody loves the 2-for-1 aspect of coming in and being able to do, it's like a department store. You can do all your errands in one go, and people like that, not having to come back again or go to another clinic for this or that. Postnatals, these people quite often come back within the first 7 days with their new baby for that baby checkup, and of course their 6-week postpartum. This is the time when I really am able to zoom in on relapses, because we know from training that mothers quite often quit for the baby, not themselves. So once they get that beautiful, healthy baby, they sometimes forget about secondhand smoke. So we just want to reiterate that this is a lifetime situation and support them through that. And of course, there's a lot of emotions and hormonal changes at that time, so we just want to encourage them. Just great resources through Canada, just to remind you, and they're right in the guidelines, and they give you a wonderful list: pregnant, mother risk, and because we don't want to forget the dad, the right time, which is a great resource for dads. The second high risk population is youth, young children and adolescents, so it's every visit, every time. Again, I'm doing the preventative, so I like to ask all ages. Sometimes I have to do it in kind of funny ways, remembering that first time these babes come to us at 7 days, but with birth at 10 years, we're constantly watching for smoking exposure in the home, and 10 years and older, clients use. So I can tell you from previous experience, I know that you know this in your hearts too, that if you ask any child who's 10 or 12 in front of their parents if they smoke, I'm sure the 99.9% statistical answer to that question would be certainly not, because you'd have to be dumb to admit that in front of your parents. So one of the ways around that is to whisk them down to our room down the hall and just say to mom or dad, hey, we're just going to weigh and do a height on Johnny, just to make sure they're growing properly. We'll be right back. And that's the time that I ask that question, because are you smoking daily, occasionally? Because they'll gladly admit it to me, just not in front of the parents, and then you can go from there. Adolescents and teens, always remember again to ask any form, because they don't consider blunts, marijuana, shifka pipe smoking. And of course, I'm always with my CRE doing asthma education, so it's a huge thing for asthma. Nicotine replacement therapy, or bupropion, as we know, are safe in use, but there is no evidence to the effectiveness. So we really want to zero in on asking and counseling, and if we can catch these kids before they even start to experiment, that's even better. And for First Nations, I'll talk about this, but these kids tend to start smoking earlier. Resources for Canada guidelines are Quit for Life, stupid.ca, blast. So if we have kids in the practice, you really want to zero in on these, because they love internet things and chats and tweet and Twitter, and that's how you can really get them and support them. So the last slide I'm going to do is mental illness and substance abuse. So Margaret, as we mentioned earlier, does a great deal of family practice, mental health counseling for people in our practice and also for other people. She's extremely good at it, very allowing with her time, anxiety, depression, bipolar, ADHD, learning problems. And she has built a huge number of clients who come back to her. So we know that people with mental illness are 2 to 4 more times more likely to smoke, 40 to 90% compared to 17% in the general population. And we know that nicotine triggers the release of various neurotransmitters involved in psych disorders with reinforcement effects of some addictive substances. So I think you know from now, from seeing how we work, that it gives these people a great chance to also be involved in smoking cessation, certainly not in a crisis period or in a high anxiety period, but as Margaret counsels them and gets them on the right meds over time, we plant that seed at the beginning, and usually by 3 to 6 months, they're willing and have the confidence to work on smoking cessation. So Margaret's just going to talk about a case study that we had in our practice now, and we'll go from there. Sure, yeah.
Because it's kind of related. Yeah. I'm just looking at the questions because as a learner myself, I always like to have my questions answered in context. So Does smoking cause miscarriages is one of the questions. So there seems to be a small increase. What the point that Karen was making was just that if you put someone at NRT in the first trimester when there's a very high, that's when the highest chance of miscarriage occurs. The NRT is unlikely to cause the miscarriage, but if the patient miscarries, happens to have their miscarriage while on NRT, they will tend to associate the two. But most of the literature does say that people who smoke do have a little bit higher rate of miscarriages. It's always hard to say, is there a direct causal effect, because we know there are many other factors involved, like people who smoke versus people who don't smoke probably have more differences than just the smoking. So, but there is an association. And do you want to answer that?
Yes.
That one?
Yes. So Marcy, that's a great question. How do you suggest to do follow-up? Scheduled appointments, monthly phone calls. So I'm going to talk a little bit about this at the end of the presentation, but because these people are coming in frequently, be it prenatal or they're coming in for asthma checks or COPD follow-up, or just general physicals, it's just continuous follow-up that's able to go on. If they are enrolled in the STOP program, I'm seeing them every 2 to 4 weeks, or in the beginning sometimes twice a week if I need to. But you know how yourself, you go to the family physician all the time for all these other things? Well, I'm always there, so there's always that follow-up. Yes, there's phone follow-up too. I have people that have accessibility issues, may live 25 miles away and can't get in, then we do phone follow-up. But so basically, because they're constantly coming into the practice, I'm always there. There's just this constant follow-up. And it's funny because people tend to ask us when we'd like them to come back, but that's an excellent question. Oh, and Karen tells me, and this is news to me, that stupid.ca is no longer available. So that's unfortunate because it was a really good program. So thank you. So Margaret's going to talk a little bit about the case study now.
Okay. Can you move the slide? Okay, so this is just one example of a person who we will call Kim, who is a single mom working in construction, came to the emergency department where I was working at the time doing a shift, and she had an acute exacerbation of COPD with some crisis and stress issues related to her son, who had learning disabilities and school issues. And her mother had recently died of lung cancer. She was worried that the same would happen to her. So what happened eventually is, yes, because of these issues and because I knew that she needed sort of intense COPD and smoking type things, I took her on as a patient. And so her history was that she had smoked 35 cigarettes per day, starting at age 22, which is actually a little bit older than most people. And and she had her first cigarette between 5 and 30 minutes after awakening. She had had several attempts to quit, including all these that you see here, had gone to. We have another program in our family health team for smoking that isn't quite as integrated. Well, it's not integrated into the practices in the same way. So she had done that. She had cocaine abuse in her 20s, but seemed not to be an issue at the time. And her PFT showed mild, moderate COPD and asthma. Okay. So, so Karen got involved in her care when she came to see me and did motivational interviewing and emphasized personal choice and control, asked permission, all these things that are part of how this is done. And yeah, and got to understand the patient's perspective on it. So, why don't you tell me about this one?
Yeah, so this is one of the things things that I learned at one of the first teach things that Margaret and I went to the core together, and one of the things that we learned, I think it was the chronic disease elective, was agenda mapping. Now, Margaret doesn't like squares as much as bubbles, but so I started doing this in the office with several patients. So for Kim, it was making a list of things in her life she wanted to change and writing in either a small box or a large box which was most important. So stress was a huge box, smoking, and COPD. Those were all things she wanted to work on. And of course, Margaret started doing counseling with her for stress, and over time, COPD and smoking went nicely together. And we've had several people come back 6 months or a year after they've conquered all their agenda mapping issues and pick out this little crumpled up piece of paper in the back of their pocket and hand it back to us and say, I've achieved all these goals. I've changed all these things. I'm going to carry this paper forever. So even though it seems like a really simple thing to do, it's worked with several of our patients. We just really want to encourage you to go and use this.
Okay, so then she began having a series of joint office visits. So I would see her for her stress counseling, and then Karen would do the COPD. And her stress and anxiety got under better control, and her COPD and asthma improved. And then she decided that she wanted to start working on her smoking cessation. So she was quite successful and was smoke-free this was a couple months after she started, and felt more in control of her stress, and also had a COPD and action plan in place. And yeah, so she's doing relatively well. Her stress isn't completely controlled, but because she is a single mother in a construction job, which I think is physically strenuous and that type of thing, but she's doing quite well. Oh, small successful steps in one area may lead to progress in another.
So the other thing we just wanted to say about Kim was on the bottom of that one slide was that the last addiction is always the hardest to give up. And she found actually smoking harder to give up than cocaine, if you can believe it. And it wasn't because it was the last of her addictions, the last of her crutches. So it's always important to remember that as time goes on. And I'm just looking at the site again because we're trying to be sensitive to the question. So the Ontario Lung Association, thank you, has written the Lungs Are for Life modules are available only as PDFs on our resource website. So if you can see where she's typed that, that's available, so that's great. And I think Aldona wrote a question, does COPD continue to worsen after one quits smoking? So we know that smoking cessation is one of the few things that we can do to stop the progression of the disease. It's a different situation for idiopathic pulmonary fibrosis, but it doesn't make the COPD better or reverse it, but it'll stop it from progressing. So I hope that answers that question. COPD can be quite a progressive disease, and we know that quitting does slow the progression. And actually, if any of you have availability to the wonderful chart that shows 4 hours, 8 hours, 1 day, and it goes right across to a month to a year of how things improve, heart and lungs improve by this amount. It's a great visual for your patients where they can see over time how things can get better. So I'm just going to talk about the last of the vulnerable populations. Hospital-based populations, I see this as the biggest gap. So I worked in a hospital for 28 years before I worked with Margaret and David in this role. And I know how hard nurses work there and how programs keep putting into place. And sometimes we put programs into place, but we don't train people to do them. And that is a huge gap in this. So all hospitals right now are supposed to have a system in place to identify smokers, to manage nicotine withdrawal during hospitalization, to promote long-term cessation, and provide follow-up post-hospitalization. I guess, as I've just said, the hospitals has a system in place, but no trained implementers. So once again, this kind of falls on the nurse's shoulders and of putting the patch on and because we know people can't smoke on hospital premises anymore. So if you haven't already figured it out, Margaret picks up orphan patients. So on a Monday morning, I always know without being told or asked that Margaret has done ER rotations over the weekend or has been in charge of inpatients, because she will always come back to the office on a Monday morning with adopted patients, be it COPD patients or people that need help with smoking. So we found, because we saw this huge gap all the time, we felt that we needed to follow these people better. Most of our COPD and congestive heart failure patients are seen now within 7 days. The goal is, to have these people not readmitted, because it's becoming such a huge issue and it's very costly to the government. So what I wanted to do is just show you an example, not to be critical, but a discharge order set of a case study. So this is a 53-year-old female discharged from the hospital post acute exacerbation of COPD. She was actually intubated in the ICU for several days and was not expected to be possibly to live. They had actually asked the family to make a decision about a DNR, and the family wouldn't do that because she was so young. She was eventually extubated and did get home, but I want you to pay attention to the fact she was smoking 40 cigarettes per day since the age of 15. She's now 53. So again, pay attention to how much she smokes. 40 cigarettes per day since age 15, and she's 53 now. So what I did was I scanned in the order set. I took off personal information. I know it's kind of sketchy. I hope you can see it. And I know as healthcare providers right now, you're just going down through that list and seeing all the meds she's on. So she has some psych issues. So that's where we're seeing the benzotropine, and I want to make you aware the Wellbutrin XL was for her psych disorders, not in any way for smoking. Of course, you can see her Spiriva and her Ventolin for her respiratory. She's also on oxygen. But what I wanted to show you was I circled the patch, nicotine patch, 7 milligrams daily for 2 weeks and discontinued. So I think if you just go back to the previous slide and I remind you of how much this lady smoked a day for how many years, that most of us would know that a nicotine patch of 7 milligrams daily during her hospitalization with no short-acting lozenge or gum or nicotine inhaler, this lady was pretty well from the time she was intubated in major withdrawal, which no one really recognized. And this was a huge nightmare for this lady. And then she was just keep the patch on for 2 weeks and discontinue it, and had no post-hospitalization counseling. So this is just an example of a visual of how we put a program into place, but we really don't support the patient. We actually set them up to fail and give them just a terrible withdrawal. So that was our biggest gap. The Canada research gap effective feels that hospital counseling and relapse prevention once the client leaves the hospital is huge, and they actually cite this as a huge gap in something that we need to do better with in hospitals. So because we were able to identify this, we went back to the Smoking Cessation and Family Health team, in our Family Health team, and since these people were being followed and watched for COPD when they were in the hospital by our other COPD educator, we also decided at the same time this would be a great time to bring the STOP program into the hospital. We have a relatively small hospital here with 23 physicians, all that are on board. So we were able to bring the STOP program to these patients in the hospital, get them signed up and enrolled so they were on the right amount of NRT and short-acting NRT, and then follow-up. And this has had really great effects, and the nurses love it too because they don't have to worry about slapping the wrong patch on or not doing the right things. So this has become just a seamless care for COPD and smoking. Can't emphasize enough the importance that if we continue this hospital program before we made these changes, people, nurses, pharmacists, we all need to be teach-trained, have knowledge of the Ottawa model for smoking cessation, and have CTEs in hospital settings. And of course, again, Canada has great guidelines for that. The last vulnerable group we just want to talk about, of course, is First Nations, and we talked about the reservation within 20 miles of our area, and that we do have rostered patients with us from the reservation, always needing to be aware of being culturally appropriate and having the proper sensitivity in that. So this is just an example of one of the patients actually Dr. Beach had in her office. He was a policeman on the reservation. He came for his diabetic visits every 3 months. We got to know him well, and then he got more short of breath. He was a smoker. We sent him for a PFT. It turned out he had COPD. So I suggested while he was in for his diabetic visit and we had gone over the PFT, we could do some COPD education and get him on the STOP program, told him all about it. He signed up. He did amazingly well, ended up completing all his COPD education, had an action plan in place. So out of that came curiosity because he went back to the police force and told them about it and about people on the reservation. So other people started coming to see what the STOP program was about. One couple came and they had heard about it, but they didn't buy in quite so quickly. So I said, hey, I'd really love you to, they were very internet savvy, I'd like you to go back. Here's a list of all the Canada Aboriginal resources. I'd like you to research them for me, tell me what you like about them, what you don't, what maybe could be done better, and they went back and did that and eventually came back for smoking cessation and the STOP program. So there's just lots of ways to get people on board, word of mouth, but again, just giving them that homework assignment was what kind of brought them in. So take-home message for this vulnerable population is we cannot ask early enough for people on reservations. So children as early as 6 to 8 start smoking on reservations. They do certainly on ours, and I know they do on yours if you ask, with increasing uptake between 10 and 12 with a peaking at age 16. So there's lots of great culturally appropriate methods and resources in the Canada guidelines for Aboriginal resources such as kicking the addiction and whatnot. So I encourage you, if you have people at a nearby reservation, that you can just go onto the Canada guidelines and follow those through. So again, we're showing this slide because if you take nothing home today other than follow up, and follow up, we want you to remember this slide and show you how you can incorporate Canada guidelines into your family practice, because those 5 vulnerable high-risk populations on the right side of your screen go so well into the left side of your daily family practice. So just one stop does it all. We ask in any form, are you smoking tobacco in any form? At any visit, we can provide smoking cessation counseling and education. We offer the STOP program within the office setting. I'm one of 3 implementers. We can combine the STOP program, which is free NRT for 26 weeks, with counseling with Zyban. So Margaret can order that at any time. She's a doorway away. And she can also order the Champex, and I can do the counseling. We always want to remember, sometimes people come knowing what they think will work for them or what's worked from their friends, so you always want to be open to those suggestions and what they feel most confident in. Again, we're dancing with these people and letting them lead. We are not fighting with them. And recently with Dr. Selby's help and supervision, Margaret and I did a combination Champex and Zyban based on the Albert et al. Study with counseling. We're looking for the stages of pre-computation, and in that leaving open invitations. So numerous times I have left open invitations in that 1-minute brief intervention, and numerous times people have walked in 2, 3, 6 months later, sometimes on a Friday at the end of the day, and said, hey, I'm ready now. And Margaret and David are great about making this a priority, because we always want to never send these people away and say, come back next week, I have an opening. You want to strike while the iron's hot. When people are ready, they're ready. So the seeds you planted earlier will eventually become plants of change. So we do joint appointments where we're combining chronic disease management, COPD, asthma, referrals and follow-ups, and smoking all together. So it's like going to the department store and doing one-time shopping. People's time is very valuable, and they love the fact that they can come in and do everything at once. Any visit at any time could be the beginning of smoking cessation. So we call it, if you build it, they will come. This is kind of like Fields of Dream, but in family practice, and this was one of the questions earlier about how do we follow up, but in family practice, people keep returning for physicals, for different ailments, for prescription renewals. We keep asking. We strike while the iron's hot. We keep following. Follow-up visits never end, no matter how many years these people have stopped smoking. And quite often it's funny if people come in for a physical and I'm seeing initially and doing their preventatives before I could even get to the smoking one. Maybe it's been 18 months since they quit. These people will say to me, aren't you going to ask me if I'm still smoke-free? Because they're so proud of it and because they want that continual affirmation. And we don't want to disappoint these people. We want to continue following them. And one of the things that we found over time is that if we continue to follow them because we've had that initial exposure to them, that follow-up works better. So an example of this was just a great summer student who was a nursing student this year in our family health team, and one of the things she thought she'd like to do is do follow-up phone visits for people in family health teams who had not returned or been smoke-free. And it was a bit of a project for her, but she didn't have a lot of success with it, and yet she was really zealous about it. And I truly believe one of the reasons that she didn't get a lot of buyback was these people had not seen her initially. They didn't have the confidence in her. So it's always good if you started the smoking cessation that you keep doing that follow-up. What am I doing here? Just got a couple more slides. So Dimitri, I see you're on board there. I saw hi, Karen. That gave me a great deal of confidence. Thank you. So if you're not using the STOP program in your family health team, I cannot tell you how amazing it is. I did smoking cessation before the STOP program came into our family health team, and I thought it was a pretty good program, but man, the STOP program is my right hand now for smoking cessation. It is so important that we can give these people, we can offer them something, remembering the reservation is closed, cigarettes are cheap. So we can give them not just the counseling, but we can give them the free nicotine replacement therapy for 26 weeks. And I can't thank Dimitri and the team enough for all he's done for our family health team and for Margaret and I. He's just so amazing, as is the rest of the team. So just a couple of slides, and then we'll go back and look, because I think there's been some questions here. And I realize these aren't paired t-tests statistically, but they're just examples here. So the STOP program will send out these to give you an idea how you're doing and accumulated value. So in this one, you can see the date for the time period it was. So in this period, the orange bars show you monthly enrollment rates and the number of enrollments, and the purple are accumulative value throughout the time period. So over this time period, 218 people in our family health team stopped. These are in my early days of smoking cessation. So you can see in that period, at the bottom of the screen, I think I did 42 out of 218 of these people, which was 19%. And then what is not included in here is non-stop, such as Champix or Zyban or combination therapy. So our stats in that period for 3 months follow-up was 83% for 3 months quit and 6 months for 6 month quit. And as I said, I realize these are paired t-tests, but it just gives an idea of how successful we were in doing this in family practice, and that's really the point of the slide. The second one was another STOP program that was put out for that time period. So the most important things are a 3 month follow-up and a 6 month follow-up, and then the middle screen shows your family health team and all family health teams. You can kind of correlate there how well you're doing compared to other family health teams. So there's a couple of things on these slides that you may be asking what they are. They aren't that important for what we're trying to show you today, but I will address what they are, thanks to Dimitri helping me with this. So you can see 3 month follow-up, 7-day PPA and ITT. And for those of you that may be really smart and wondering, a PPA is a 7-day point prevalence abstinence. So it's a validated question highly correlating with quit date. It's a marker for quit weights, and it's a self-report tool. So we know that the STOP program follows people by email or phone call every 3, 6, 9, and 12 months while in the program, or we can go on and do that if we have the time as well. That's over and above our regular follow-up. And ITT is an intent to treat analysis. It's a specific research term. It accounts for, It can account for dropout rates. It's not a great tool, and I believe we're not using it now because it assumes that those that didn't respond to the surveys by phone or internet are still smoking, and sometimes that's not the case. What is the purpose of the slide is just in looking at our family health team for 3 months and 6 months, 34%, 37%, that in that same period, our patients were 86% for 3 months quit and six months for stay quit. So extremely high. And I just wanted to tell you what we feel some of the reasons for that pilot was and the results. That I do smoking cessation for both the family health team and in our family practice as one of 3 implementers. There are 2 other implementers in our family health team, amazing pharmacists, and 1 other family health team COPD educator. My stats were better for 3 or 6 months in that same time period, but not because I am a better smoking cessation counselor. I want to make that really clear. But we really felt it was because there were more visits in the family practice, more encounters, and the consistency of constantly being seen with the physician at the same time as the smoking cessation counselor. I also had amazing physician backup with Dr. Beach and Dr. Tromp in that we were able to, within 1 minute, combine therapy with Zyban and the NRT and the STOP program, that there didn't have to be a phone call to the doctor and have you come back another day, and by then you lose that momentum. And the correlation that you could do COPD, asthma, pulmonary fibrosis, and diabetic education at the same time. So there's just this huge consistency of that. So Margaret's just going to talk for a minute about counseling and psychosocial approaches.
I think. Okay. So, yes, I think with our counseling, we do different ways of approaching it. So, the more sessions we have, it tends to prolong the absence or their abstinence, and we can deliver it by a variety of formats. So I think it's good that the patients come in, and whatever they're in for, we can talk about their smoking briefly or for a longer period of time or whatever works. So say they're in for, I don't know, a sinus infection, and you say, oh, do you still smoke? And, do you want to do anything about that? That might be the end of that, or this might be the time that the patient decides they want to do something about it. So then Karen talks to them about that. So, and as you know, because we're, readily available, if the patient does need a prescription medication to help them, we can easily do that as well. So that's the same thing again that we've seen. Okay, I'm going to let you do this one here.
So some of the recommendations is that the CANADAP guidelines can be the right hand of smoking cessation in your family practice. Now that you've seen this presentation and remember that chart, I think you could begin to see ways that you have those 5 vulnerable populations in your group, and you could start feeling that you could implement the guidelines and use the resources. Keep asking about smoking any form. Integrate smoking cessation into your CDM program in your office. Integrate smoking cessation into all aspects of lifespans of your family practice. Please be aware of the gaps in hospital-based systems related to managing nicotine withdrawal during hospitalizations and providing the proper follow-up. And hospital-based systems need trained smoking cessation counselors to be totally effective. Train your staff, teach. I'm just in love with teach. Make sure that you can get some CREs and CTEs in your family office. The core courses and the electives are amazing. The STOP program for family health teams can have implementers in family practice within a family health team. So they don't just have to be within the smoking nurse in the family health team. The more of you that can get trained and be implementers in your family practice, I know Dimitri would love to have more and more people involved in this route. Use the tools and resources that we've talked about in CANADAP guidelines. Take a motivational interviewing course. So Jennifer Lopez wrote, do you have MI online? So if any of you are interested in a motivational interviewing course, the Center for Addiction and Mental Health and the Lung Association through the motivational interviewing respiratory care. We actually go out. If you're interested, you can contact either, and we do free courses, 4-hour or 8-hour courses. There's many of us trained, and we will come free to different colleges and whatnot and do motivational interviewing for you. Statistically, the pilot showed smoking cessation was more successful in family practice based on the Canada counseling and psychosocial support. And those are our references. And I'm just laughing because all my friends at CAMH are writing me notes to encourage me. I love you guys so much, Meg and Myra. Thank you. And Margaret and I are laughing because we want to know if Jennifer Lopez is the actress and the wonderful singer, but we probably know she isn't. And Dimitri, if you have anything you'd like to add, I would love for you to unmute and say anything about stuff that you would like to. Oh, he has a technical issue here, I think, so he can't speak. But anyway, just contact CAMH and the STOP program. I don't know, Tanya, are we okay for time to take a few more questions or no?
Yeah, we have a couple of questions, and then if it's all right with you, I can just collect all the questions afterwards, and I could post them on the website after if you guys are able to answer them.
Okay, so I'm just kind of scrolling. Some of you are being very affirming today, and thank you for all your lovely comments. I think, Aldona, I answered the one about enrolling in an MI course. Connie at the Lung Association can arrange for several of us to come free and present for you, and I can give Tanya that information after to send out.
Perfect.
Anything else on the questions, Margaret?
So the next question here, Darlene asked, overweight and obese people that are smoking are afraid to gain more. How do you deal with or help that when they want to quit?
So if you go back to that teach training, there's a wonderful, wonderful chart and algorithm based on what some of their fears are and when they want to quit, if they're worried about weight gain. There's certain drugs that work better than others, say Zyban over NRT over Champix. So that's something you can take into consideration. It's an amazing algorithm, and it just helps because, again, you're asking the right question. You want the patient to lead, and if that's a fear the patient has, that's one area that you can use a certain drug that works better than the other for that, as well as the finger foods and nibbling and increasing exercise. So, but yes, that's a huge thing, right, is weight gain. But there are some drugs that work better than others for preventing that.
And then the next question I have here is from Jennifer Lopez. How effective is the internet Skyping smoking cessation counseling? With your expertise, how do you feel about Skype counseling with regards to smoking cessation?
So we also use, Smokers Hotline and all those kind of different things in, this is a social media world, and tweeting and twittering. I don't tweet and Twitter, but because Margaret won't let me do it in the office or I get fired. But we want people to use what works well for them. I encourage people to use Smokers Hotline as well. Anything that's added counseling and help is great. As long as they're legit. Always remembering, though, that you're that first line in that person's life, so you just want to...
So I think Jennifer might be asking, do we do Skype counseling ourselves? And that, potentially would be something you could do with patients. Karen does telephone counseling, and we don't have patients from really far away who, have to spend hours driving to the clinic. But I think that Skyping would be similar to doing telephone follow-ups. I'm not sure that it works so great from the core if that's all you did. Because I think knowing the people personally and having that personal relationship is what really adds to the effectiveness of it.
Okay, I guess we'll take one more question. In a smoker who is also an alcoholic, which is better to target first to stop the addiction? Smoking cessation or alcohol cessation?
So I think statistically there's a lot of things out there, but I just want you to go back to agenda mapping and let the patient choose. So going back to Kim, the cocaine addiction was, in my mind, a huge addiction compared to smoking. But because it was her last addiction to give up, it was the hardest for her. And it's the same with the stage of change. We always want people to make the choice, because if we decide for them and it isn't what they really want to do, they won't buy in. So sometimes what the patient chooses maybe statistically in research will not be what might work the best, but we want to motivate people. We want them to be in charge of their life, so we want them to agenda map, and if they want to quit one before the other, then we support them through that.
Okay, so I guess we'll wrap up. I can gather all of these questions, and if you still have questions, please feel free to continue typing into the chat box. It will save. And just to wrap up quickly here, please remember that a link to the evaluation and post-learning assessment will be emailed out to you by tomorrow morning. This is a requirement to receive your letter of completion for today's session. And again, if you participated as a group or called into the teleconference line alone, please be sure to email me by end of day today. My email address is on the screen. And the